Last video was a bit disorganized, so I have tried to make this a bit better organized. Uh, this is for my revision, and the byproduct is if it helps you, then it is good. Because I don't have a study partner, so I am taking this approach to teach someone, but teaching someone is always a better form of revision. Okay, so coming to prolactin. So the action of prolactin is on JAK-STAT receptors. JAK-STAT receptors are on the cell membrane, and this is also a protein hormone. So it acts on the cell membrane receptors, JAK-STAT. And what does it do? It acts on the estrogen primed breast tissue to cause the increase of and maintenance of lactation. Increase and maintenance of lactation. So what are the hormones which causes the stimulation of prolactin? One is estrogen. Another one we have studied in the previous one, it is TRH. Another one is VIP. It is a GI hormone. And another one is the oxytocin, which causes the ejection of the causes the ejection of the milk from the mammary ducts. This causes the synthesis, oxytocin causes the release. And oxytocin has many other functions also. So what are the drugs which causes the stimulation? First, we need to know that what is inhibiting the production. It is inhibited by dopamine, that is known as also the prolactin inhibiting hormone. Okay, so if dopamine is decreasing, so increase will be caused by D2 blockers. D2 blockers are our antipsychotics. That is, risperidone has the most D2 blocking property. Risperidone. Another can be our prokinetic agents. Okay, antiemetic prokinetic agents, that is domperidone and metoclopramide. Another one is our antihypertensives. Those are alpha methyl dopa and verapamil. Another is our H2 blocker and the opiates. Okay. And it is produced from two sources, not just from pituitary. Obviously, it is produced from pituitary, the lactotroph cells. The lactotroph cells produce them. These are also acidophilic cells. The release from the lactotroph cell is regulated by dopamine. Okay. The another source is our placenta, uterus, and some other parts of the brain. Okay. These are not under the control of dopamine. placenta, uterus, and other parts of the brain. Okay, so this is the action. So what will happen if there is hyperprolactinemia? Hyperprolactinemia will cause galactorrhea. Because of this, prolactin also has an inhibitory role on estrogen, so it will also cause amenorrhea. The main cause of lactational amenorrhea is because of the increased prolactin in the lactational period. Okay, the oxytocin is causing the bonding with the parent. The mother and the child bonds due to oxytocin. That oxytocin increases the stimulation of the chest stimulation. That oxytocin and the chest stimulation causes the increased production of prolactin, and that prolactin causes lactation. So increased prolactin, the features are going to be galactorrhea and the lactational amenorrhea. So amenorrhea, and in case of males, it is going to cause erectile dysfunction and loss of libido. And in case of male and female both, it is going to cause osteoporosis and insulin resistance. So okay, so what are the features? Galactorrhea, amenorrhea. In workup of amenorrhea also we have to do prolactin along with LH-FSH. Amenorrhea, and in case of males, it is going to be erectile dysfunction and loss of libido, and in case of male and female both, it is going to cause osteoporosis and insulin resistance. So with the patient coming with such clinical features, we are going to do prolactin levels, fasting prolactin levels. Okay, it can be less than 25, it can be 25 to 40, it can be 40 to 100, it can be 100 to 250, and more than 250. Okay, 250 and more than 250. This is fasting levels. Less than 25 is normal. This is a physiological rise. This can be due to chest stimulation, or because of pregnancy, during lactation, and during REM sleep, and due to stress. So physiological rise can be due to chest stimulation, pregnancy, lactation, during REM sleep. In non-REM sleep, we have studied that growth hormone increases, and in REM sleep, prolactin increases, and stress. These are causing physiological rise. And 40 to 100 is due to either due to drugs or due to systemic disorder. Drugs are these drugs. So drugs or systemic disorder. What are the systemic disorders? It can be PCOS, or it can be ESRD because the excretion is lost, ESRD. And in case of this TRH, so same goes here in case of hypothyroidism. The range of 100 to 250, it is due to it leads to a suspicion of tumor. If in gadolinium MRI we are getting a mass with decreased echogenicity, that is hypoechogenic mass with patchy uptake, then we are confirmed that this is our tumor which is causing this hyperprolactinemia. If not, then it is a false positive case. What can be that? That can be because of macroprolactin. Macroprolactin is a non-functional prolactin which if increased, it can show as a increased prolactin, but is not produced by a tumor, or neither it is causing any functional disability. And more than 250, this is a tumor. This has to be a tumor, and after 250 the value is proportional to the size. More the size, more is the prolactin level. So in this gadolinium MRI, we are finding prolactinoma. So coming to prolactinoma. What is prolactinoma? A tumor secreting prolactin of pituitary is known as prolactinoma. This is the most common functional tumor of pituitary. Okay, most common functional tumor of pituitary. And this is most commonly microprolactinoma. Matlab, it is less than 1 centimeter in size, and it is associated with certain syndromes. Growth hormone producing tumors are also associated with these syndromes, that is Carney's triad, Men-1 syndrome, and our McCune-Albright syndrome. McCune-Albright syndrome. So, going for the workup, we have seen this tumor, seen the size of the tumor. According to the size, it can be less than 1 centimeter, that is 90% case. This is known as microprolactinoma. It can be 1 to 4 centimeter, this is 9% case. This is macroprolactinoma. And it can be more than 4 centimeter, that is 1% case, that is giant macroprolactinoma or giant prolactinoma. Okay, so now we will in growth hormone we went for surgery directly, but here we will first go for the drugs. In less than 1 centimeter, which is the most common, it can be symptomatic or asymptomatic. Means it may be an incidental diagnosis. If it is an incidental diagnosis, that is, it is asymptomatic and the size is less. If it is asymptomatic, then we are going to watch. Okay, we are not going to do anything. Okay, we are just going to follow up. Okay, so this microprolactinoma is normally more in females than male. It is 20:1. This kind of high ratio is very rare. Normally 9:1 in autoimmune cases we find, but this is 20:1. Means mostly females suffer from this problem. And asymptomatic, we are not going to do anything. And in case of symptomatic, we will go for cabergoline. Okay, cabergoline. It is a D2 agonist. So D2 blockers are going to increase. So D2 agonist is going to decrease. It is given 0.25 mg twice weekly for 2 years. If this is not responding, symptoms are not remitting, okay, and the size is also not decreasing, then we can go for surgery. Okay, and in case of pregnancy, we are not going to give cabergoline, we are going to give bromocriptine. In pregnancy, the drug of choice is bromocriptine. Okay, and after 1 month, if there is no response, we'll go for surgery. In pregnancy, we have to do the surgery fast because there is a chance of pituitary apoplexy. Okay, and symptomatic and macroadenoma and giant adenoma, the management is the same. So what are the indications of surgery? One is when it is not responding to the medical treatment. Another can be pituitary apoplexy. Another can be the mass effect. That is, the size of the prolactinoma has increased so much that it is compressing the stalk. So due to the compression of the stalk, the other hormones which are supposed to be secreted from the pituitary is not getting secreted. Okay, so due to the mass and the stalk effect, if there is that present, then we are going for surgery. Okay, and obviously the drug resistance or intolerance, if the person cannot tolerate drugs, then also we will go for surgery. And how long do we have to go continue the drug? For 2 years. Okay, so we have completed our prolactin.